thank you all so much for coming today. As you heard, this is probably the most knowledgeable group in stethoscope hygiene in the United States. Certainly one of the most well-published group of authors that we have. So this is the brain trust for stethoscope hygiene, and thank you for spending your time today. The first thing we're going to talk about is a phrase that was coined by Alpesh Amin, the clinician's third hand, the stethoscope, and it's a significant overlooked vector in infection control protocols. This is an issue of both the viability of the stethoscope as a tool and its function as a vector, and so whether we clean it or not. And so I wanted to turn this over to you a little bit, Alpesh, to talk. You're the guy who coined the phrase, and how did we get there, the third hand?
So take a look at what we're dealing with. Patients come into the hospital to heal. Yet we have 1.7 million hospital-acquired infections that occur annually in the United States. $150 billion of both direct and indirect cost. 100,000 lives have been estimated to get impacted or die because of hospital-acquired infections. If you add nursing homes into that, now you're talking about 400,000 lives that are impacted. This is a problem. Right? And we should be doing everything within the hospital setting. And now, actually, as the continuum of care continues beyond the hospital, clinics, homes, across the continuum, we should be creating systems that are safe for our patients. Bottom line. Well, okay, washing hands, once you do that, we see that there's improvement in the transmission of infections. But then you sit here and you go, well, the most used instrument in healthcare, arguably, is a stethoscope. It doesn't matter what specialty you're in, whether you're a doctor, a nurse practitioner, you're using a stethoscope. And respiratory therapists, you're using a stethoscope. Now, so the question comes up, is the stethoscope a vector for transmission of infections? We know the hands are, so it makes sense that the stethoscope must be a vector for transmission of infections. And actually there have been studies that have shown that both the density as well as the diversity of pathogens that are on a stethoscope are exactly the same as they are on a hand, right? So now you've got another vector besides your hands that can transmit infections from patient to patient. So in 2015, we decided to do a very simple study looking at what's the culture in a hospital general medical unit, general medical floors, in cleaning stethoscopes. And we found out that it was pathetically low. That's right? So we focused a lot on the hand, but we weren't focused on stethoscopes. Right? So that created the opportunity for us to to coin the term the third hand.
Yeah, it's sort of amazing that we have all this effort on washing our hands, and then you grab your stethoscope and you completely defeat it.
You completely do.
You might as well just have skipped it.
Yep.
Alan, you've done some studies on how effective people actually wash their stethoscope. What do you find out?
Well, over at the Veterans Hospital, we put people in the vicinity, as being part of rounds. And we studied a couple hundred of these doctors, mostly doctors, some nurses. And we found out that a mere 4% really did adequate stethoscope cleaning. Now, we did a survey after to ask who cleaned their stethoscope. And believe me, 4% did not answer that they did. It was about 50% said, oh yeah, we cleaned them. So they're embarrassed about it and they don't want to admit it. But also, if you think about it, we just heard about how important hand washing is. Can you imagine if only 4 out of every 100 patients we saw, we washed our hands? Can you imagine? We'd probably be in jail, And the patient advocate groups were the ones that saw to this. They had pretty soon they had signs in elevators. Patients, ask your physicians to wash their hands. Well, I'm sure in the next year or so, patients, ask your physicians to cover your stethoscope. This is going to be very important. Now, one other thing we saw, quite amazingly, there was about 13% of doctors who actually took their stethoscope, put it in a rubber glove, and listened through that rubber glove. 13%. So these guys, they recognized clearly the value of having a barrier there, you know, and really and these are some, you know, and I've seen this myself. Our chief of infectious disease, the university would never go into an ICU where there's sepsis precautions and use one of the disposable stethoscopes. He wouldn't do it. He always wrapped it in a glove so that he could hear what needed to be heard. So really this right there, this is a clean ask to have a stethoscope barrier.
Well, and it's not just are they doing it. So we published from the Southside Chicago Hospital, community hospital. We went and asked the docs, are you cleaning it? And 35% said yes. And then we grabbed their stethoscope and we cultured it. And maybe they didn't clean it and they just didn't want to admit they weren't cleaning it, or maybe they cleaned it and it just doesn't work. But at the end of the day, the stethoscope is dirty. Right. And that's what you're smearing on your patients. And before COVID, I'm not sure people were that worried about it. It scares me to death now. Right. Stuart, what are you doing? You're in a clinic.
So for 20 years or so, the issue of stethoscope hygiene's been in the forefront of my thoughts. So I sit and clean my stethoscope for a minute with an alcohol wipe as I'm sitting at my desk trying to do 35 other things. And quite honestly, ask any clinician, a nurse, a doctor, a respiratory therapist, we would love to have the time to sit there and clean our stethoscopes, but we just don't. There's just too many things that happen in between patients. And what I'm doing now as a participant in the clinical studies that were done on the disc cover system and now using it in my clinical practice.
You know what crosses my mind? Stuart says he has to take he has to take a minute to clean the stethoscope. Now, if you're in a busy primary care practice and you're seeing 20 patients in the morning and 20 patients in the afternoon, and you clean your stethoscope before you go in to see a patient, and you clean your stethoscope on your way out of seeing a patient, and you're doing it correctly, it's 2 minutes per patient, 2 times 40 patients in a day, 80 minutes. It's almost an hour and a half of wasted time. There's got to be a better system.
I think this is a really, really, really important point. I've had a lot of experience with monitoring and measuring different types of improvement processes. And one of the things that we've learned is that it doesn't matter that the clinicians know what to do and that it's the right thing to do, because that is what they want to do. What really matters is having processes and technology in place that allows them to do the right thing. Even for such simple things as medication errors, we put as many road barriers in place to prevent them from doing the wrong thing. In this case, it's like we put every barrier in place to prevent them from doing the right thing. So it is what we need. We need technology that makes it simple and obvious, because the clinicians will do the right thing if you give them the opportunity and the method to do that.